Donc c'est vrai que cette matinée sera assez riche puisqu'on a vraiment deux exposés très intéressants. Alors, now we are delighted to welcome Professor Ruud Van Winkel, who is psychiatrist in Young Adult Department KU Leuven Kortenberg. Ruud is very interested in first episode psychosis. On set, he has accomplished many researches on risk factors like drugs or like genetics or family problems. And then you are also a big searcher because you have a big team of young researchers with you. And today you will share your program for Flemish Chaire Transition Working Foundation. And we are very delighted to hear you. So I give you the floor.
Thank you. Okay, thank you, Professor Delven, for inviting me, and Professor Delay for the very nice introduction. Also, I would like to express my thanks to the King Baudouin Foundation for funding all of this work, both in Flanders and in Wallonia. I think it's a very important step to make here. I would like to start my talk with an apology because I'm not doing this talk in French. The reason is quite simple, because I was born in, this is me, I was born in a country where this juice here is called Suderans, which is Dutch for jus d'orange. So my French is simply not good enough, so I hope you understand that I will try my best to do it in English. So my apologies. So the chair in transition psychiatry granted by the King Baudouin Foundation had a few main goals, I think, and the goals were to do clinically relevant research, which was very important, so it had to be clinically relevant. The second important thing was that it had to be really in a collaboration with young people and with stakeholders. And the third main goal was it had to result in measurable improvements. And a number of improvements were discussed. For example, you had to build a network across the country. You had to try to involve policymakers to make improvements in the politics, and also to improve the clinical work done for these young people. So more or less, the goal of the King Baudouin Foundation is, just here's a bit of money, now please change the world. If I'm not correct, please tell me. So we try to change the world, Professor Delven and myself. This proves to be hard, but we're going on. But as you can see, this is a very broad thing. So you have research, and you also have the real world. So the real world in terms of networks, in terms of funding, payments to the mental health care system, etc., etc. And I thought, looking at the program here today, with a lot of clinicians and people with a real interest in the mental health, not so much in the research, I thought I'd really focus on, the real world implication, not so much the research. We were doing really interesting stuff, looking at the effects of trauma, for example, on the brain, and how this, changes the way you look to other people, how you interact with other people. So I hope to present this a bit later on in the project. Today I would like to really discuss the work we've been doing in changing the clinic, changing the political landscape towards youth mental health care. And I think the first really important question is, and this is actually quite often overlooked, what is transition psychiatry? I will explain why this is an important question. Because in discussing transition psychiatry with a lot of people coming from child psychiatry, from adult psychiatry, with young people, etc., in the literature you find actually two big models. And the first model is a model where you have child and adolescent psychiatry, you have adult psychiatry, and then somewhere at the age of 18, you have to go from one service to the other. So for a lot of people, this is transition psychiatry. And if you talk about other aspects, for example, mental health care for people between 16 to 25, they say, well, this is not really transition psychiatry, that's youth mental health. Then there's the other group of people that say, no, it's not about just, moving from one service to the other. That's boring. That's only one aspect of an entire field. We have to take care of young people in the best possible manner. And this is by, focusing specifically on, let's say, the transition age range. And there's actually a bit of a discussion between these very famous professors. So Patrick McGorry is an Australian adult psychiatrist who comes from the psychosis background, who's really a favorite of what they call the Headspace program, which is focused on youth between actually 12 to 25, so a very broad range, and they do everything. So it's a one-stop shop. If you have a problem with housing, you can go there. If you have a problem with money, you can go there. If you have symptoms of anxiety, of depression, of psychosis, doesn't matter, there's a place where you can go. So it's very an integrated approach. And at the other end of the spectrum, there's this professor from the UK, Swaran Singh, who works in the UK, obviously. And in the UK, you have to go from child and adolescent psychiatry to adult psychiatry at the age of 18. And so you cannot be followed, like, for example, in Belgium, if a child psychiatrist or a child psychologist thinks it's in the interest of a young person to continue to seeing this person after the age of 18, this is very possible. This is not a problem. In the UK, this is a problem. So they have to really arrange this transition from one service to the other in a good manner. And so if you use the term transition psychiatry, both of these models are in the same discussion, and you have a lot of discussions with groups of people about whether or not one or the other is transition psychiatry. So I think that's a very important discussion. Before I will tell you what my opinion is, I would like to give a bit of a background where we actually ended up in this discussion, or where it started. And I think I'd like to start with my work in Maastricht. So when I was a young man, I worked in Maastricht University with Professor Jim van Os. And so this is, for example, a paper we published some 10 years ago, where we demonstrated that psychosis, so I'm a psychosis researcher, psychosis is really distributed in the general population. So if you look and go to the general population, you ask questions like, did you ever experience this and this and this and this symptom? About 16% of the Dutch population will say, yes, I've had these symptoms once in my lifetime or more, but at least once. So a lot of people actually declare, yes, I do sometimes have these symptoms. If you then interview these individuals, so by a psychologist in this case, are these really clinical symptoms? Would a psychiatrist or a psychologist call these psychosis or psychosis symptoms? Then about 6% of that group really has psychotic symptoms, while about 3% actually has a psychiatric diagnosis of a psychotic disorder. So this is what Jim calls the psychosis continuum. And I think this is important in understanding the entire discussion about youth mental health, because it has a number of important implications. And I think the first one is that we need to look at psychiatry not from a dichotomous perspective, like there's patients and there's healthy people, but that a bit of vulnerability is present in all of us. And the period where this vulnerability tends to occur is especially in this adolescence and young adulthood. So we need what I would call developmental models. So looking at people not from a yes or no, patient versus normal perspective, but from a perspective of, okay, this has been your life, you had difficult periods, you had symptoms which went away and didn't need treatment, or which did not really went away and you needed treatment, but you needed the lifetime perspective. That's one thing I think we need to have in psychiatry and in transition psychiatry in particular. So adolescence is really a very important period where vulnerability is at its peak, and some people will actually have the bad chance to really develop psychiatric symptoms. Well, in other people, they might have transitory symptoms that will go away, and who will then lead a more normal life. So this is what we call the proneness persistence impairment model. And so, for example, if you look at psychotic experience in 16-year-olds, you see that actually very high percentages report ever having had some kind of psychotic symptoms. And you see the symptoms listed here. Girls mainly had high prevalences of paranoid thoughts. Boys are very much grandiose in adolescence and maybe thereafter as well. But you see the percentages are really, really high. So this peak really seems to be present here. And then when you look at how these symptoms develop over time, you see that, you know, most people will have low levels of symptoms, but there are three groups that are more interesting for, like, from the clinical perspective, which is a group that has increasing symptoms. I think this is a group that had symptoms at 11 and discontinues to having symptoms, and there's a group of people who have high symptoms across this age range. And of course, especially these two groups are most interesting clinically. So the group with either increasing or persistent levels of psychosis. And so when you look at the typical risk factors for schizophrenia, you see that these are also the typical risk factors for subclinical symptoms in adolescence, with especially high prevalences of traumatic events. So this is why we're very much interested in, you know, how do traumatic events in childhood lead to a sort of vulnerability later on. And so this more or less describes how this model that Patrick McGorry, the Australian psychiatrist, developed over time. Like, okay, so we see, let's say, people with subclinical symptoms, or maybe more towards the clinical spectrum already. And so he said, well, I think there's something like a clinical high-risk state, or an at-risk mental state, or an ultra-high risk. There are many names in the literature for this. And so, for example, when you have a psychosis, clinical high-risk state, you're at a risk to develop psychotic disorder. If you have a, I don't know, bipolar clinical high risk, you have you're at risk to develop bipolar disorder. And a lot of money and time has gone into identifying biomarkers and identifying symptom profiles and identifying I don't know what, to actually be able to predict who will transition from, let's say, the high risk state to the actual diagnosis. The problem is, and this paper was published this week, I think, so it's really new. It doesn't make sense, so it doesn't work like that. So this is a review by the Irish psychiatrist Ian Kelleher, and actually what they found is when you control for the fact that these people are seeking help, so they're different than, let's say, people who have sometimes symptoms but don't seek help, so they're under stress of these symptoms. Once you control for that, your diagnostic category has no meaning anymore. So this is a problem, of course. So I mean, you have to do really, really long interviews. There's this standardized interviews that take an hour or 2 hours to really define whether or not people have an at-risk mental state. We now know we should not be doing this probably. So this is, I think, a very important finding. A second problem with the concept is when you look at transitions within this psychosis continuum, you see that, for example, this is a paper we published, I think, 2 or 3 years ago. Those who had self-reported psychotic experiences have a higher risk to continue having these symptoms, of course, but also have a higher risk to really develop what a clinician would call a true psychotic symptoms 3 years later. So the model works in that it identifies people who are at higher risk to develop psychosis. The problem, hold on. So it's able to, identify people who move along the spectrum, so to say, so from self-reported to validated psychotic experiences. The problem is this: it's absolutely not specific. So it's a risk factor for a lot of disorders or problems. For example, mood disorders, anxiety disorders, substance use disorder, help seeking, etc. Probably a lot of other diagnoses we didn't investigate as well. So it's psychotic symptoms in adolescence seems to be a measure of severity rather than a specific vulnerability to a psychotic disorder. That's the second problem, I think, with the concept that of the high risk paradigm. So this is actually the international consensus now in youth mental health. So we no longer speak of risk states because they're not so valid. The research shows we speak of, let's say, transdiagnostic models or pluripotential staging models, as they very eloquently put it, which means that people at a young age have very unique patterns of symptoms that do not really fit within the diagnostic categories we see in adult populations. And over time, and only over time, will they have a more typical pattern of symptoms. And even then, I'm an adult psychiatrist, I see a lot of schizophrenia patients or psychotic patients. I think no two of them are alike, and I know they have the same diagnosis, but one person can be really agitated while the other can be really quiet, sitting in a corner. So, I mean, the differences are very large, and in young people they are much larger. So this is, I think, a very important concept when talking about youth mental health. And so what they propose is to leave diagnostic categories behind and score young people on 2 axes. So the one axis is progression or severity, so if you will. The other axis is extension, or what they also call the complexity or the comorbidity axis. And so this gives you a much more coherent idea of how young people are doing and how severe their problems are, at least from the psychiatric point of view. So I think this is a very important concept in youth mental health. And so this is also the, let's say, the explanation why a psychosis researcher like myself eventually ends up in transition psychiatry. So this is a photo we made on the kickoff symposium of the chairs for transition psychiatry, also in Brussels. And so this is also, and I think this is important, the reason why the International Early Psychosis Association is no longer the International Early Psychosis Association. So they kept the acronym, IEPA, but they call themselves now Early Intervention in Mental Health. And this is a much better name for what they actually try to do. So, a long story to give you a bit of background on what we will be trying to do in the 4 years of the chair of transition psychiatry. And so we have identified multiple levels of transition. So we have, of course, the transition of services. If a young person is in child and adolescent care, how can you then go to adult care in a good way? A bit broader as well, how can you improve treatment for young people between the ages of, let's say, 14 to 25 or 16 to 24 or 15 to 23? I think we have to discuss which ages are the most relevant. There's no real agreement on this in the literature. And a third level is more fundamental research about the developmental mechanisms, the psychological mechanisms, the neurobiological mechanisms, how people go from subclinical to clinical and from undifferentiated to differentiated. So these are the levels we will try to address with the Chair of Transition Psychiatry. Today I will be talking about the most clinical or clinically relevant levels, which are the first two. There's a lot of interesting stuff as well in this level, but I think time is limited, and we're very much looking forward to the data we will have from the studies we're doing right now. Okay, so to start off with, let's say, the transition from one service to the other. So this is the paper by Swaran Singh, who sets off this entire literature in which he defined a good transition as having an adequate planning, and this includes having a transition meeting, so having a meeting with the young person, preferably also the family, the child psychiatrist, adult psychiatrist, other parties that are involved, to actually go and plan this transfer beforehand, around at least 6 months before. Then have good information transfer, have a period of parallel care where both the adult psychiatrist and the child psychiatrist are involved, and then following the transition, ensuring that there's continuity of care. So those are the factors that he thought were important or defined optimal transition. We know that around 5% only had all of these criteria fulfilled. So we're very, very lousy in doing this. This is what I used as a picture to illustrate that. So there's a Grand Canyon between child psychiatry and adult psychiatry. And this is the Chair of Transition Psychiatry. So I would like to look from the perspective of young people in how to address this. And we have two types of young people, of course. We have young people who are patients, but we also have young people who are trainees. And I would like to show a bit of data that Gail Hendricks, who is now a PhD student of mine, but used to work also with, and still works with, Professor Piet Tremery. And they collected data in this group of trainees in psychiatry, both from child and adolescent psychiatry and adult psychiatry, And they were asked about, what is your knowledge on the topic of transition psychiatry? And so, yes, this was not so good, basically. So only in 2 countries it is part of the training, and then only in the child and adolescent training. So there's not a single adult psychiatrist who is actually trained in transition psychiatry, myself included. So this is one problem, I think. Also, if you ask them, do you feel qualified to work with young people, to work in transition care? Well, more than a quarter does. But that means that 3/4 of them don't. And actually, most of them indicate that they need additional training. So we need to educate people better. That's a first conclusion. We also asked them about the components of optimal transition care. This is a paper that's now under revision. And then you see that actually it's not negligence. It's not that they don't care. They really care about doing this properly. So when you raise, for example, topics to address during a transition meeting, you see that involving the young person, addressing his or her concerns, involving other services, etc. People think this is important to do, but it's also not so feasible. So they lack the time, they lack the money, they lack, I don't know, the support to actually go and do a lot of this stuff. And I think there's a parallel care is not considered that important in trainees. But when you look, for example, at information transfer, again, you see they consider it important, but not so feasible. And this tells us something, I think, about the care system we have to work in, where we have lots of questions, lots of new referrals, and not so much time. So this is the part of, let's say, the young professionals. I also would like to discuss a bit about views of young people and people with symptoms. We don't have the data, as a research topic yet. So I would like to talk about the experience we had in the working group Transition Psychiatry for the Staten-Generaal. So the Staten-Generaal is actually, I think, a very important initiative in Flanders, in that the feedback we got from politicians when we asked about better mental health care, more funding for mental health care, etc., is they say, well, you have child psychiatrists, you have adult psychiatrists, you have psychologists, you have social workers, you have so many parties and people involved that we don't get a good idea of the entire sector. One person says this, the other person says that. You need to work within your sector to actually discuss within the sector what are the priorities, and then come to us, because now it's just a mess. It's chaos. And this is what Staten-Generaal tries to achieve. So it's, let's say, a discussion forum involving psychologists, adult psychiatrists, child psychiatrists, but also family members, so CMLS, all the family organizations, patient organizations. So everyone with an interest in mental health care is in this Staten-Generaal. And as a group, we discussed what are the priorities for our field. Transition psychiatry is one of them, one of the 4 priorities we have identified. And so we have now done 2 symposia where we actually presented the papers of the working group. And so we had monthly meetings with all people involved in the working group, And so from this working group, I will just give you some feedback on what young people said within the working group that I think are important to take into consideration. So this is the actual report. Can be downloaded through this link here. It's in Dutch. But other than that, it's nice to read. And so I'll first discuss the recommendations of the working group and then the input of the young people. I think the data of how poorly trained these trainees were, despite being motivated to learn, tells us something that we really need to train people better. That's very, very obvious, I think, and one thing that can be achieved quite easily if everyone involved in the training of psychiatric trainees is willing to do so. I think the second thing we identified is there's very little information to rely on as a clinician when you want to do this properly. So there are no tools, no online information, etc. So we need quality controls, and we need validated instruments to really say, okay, a young person has to transfer from one service to the other. What are important things we want to look at? Have this in a file. Okay, check, I did this, check, I did that, check, I did that. Okay, now we're ready to go. I think that's one thing which is lacking right now. A third thing which is really lacking is where to find information. I mean, we do have a website, but of course this is just a few people, well, actually one. I have a PhD student who is good in programming and who I rely on to do, everything about the website. I wouldn't know how to do it myself. But if this person is gone in a few years, I don't know how to proceed. So I think this is not a task of individual professor. I think this is maybe a task of a government to really have a knowledge center where people can go to have valid information. So this is, for example, a website that is available in the Netherlands, funded by, I think, Kenniscentrum GGZ. So this is what we need as well in Belgium. So this was one of the recommendations we gave. And finally, I think from the professional point of view at least, we need a specific number of things. And the most important thing is that you can do in a 19-year-old what you can also do in a 17 or 18-year-old. So now it is the case that a lot of things we're allowed to do from the RISIF, is called INAMI, I guess in French, stop at 18. So seeing the family, doing diagnostic work, discussing with the psychologist, all these things you can do before the age of 18 and stop at the age of 18. This is ridiculous. This needs to be at least until 23. So this is one of the recommendations we gave in the report. And in addition to that, I think we need a number of additional instruments, such as organizing a transition meeting with a young person, with the family, with the people involved, writing a specific transfer report, having some sort of parallel care. For example, if a young person is admitted to a hospital in child psychiatry, they should be able to go to an adult psychiatrist to meet and have a period of parallel care. These are a number of recommendations. And I think the most important thing is you need a clear, accessible, and affordable care system without waiting lists, because you can do the transfer process perfectly. If you then end up in adult psychiatry and you have to wait half a year, that doesn't make sense. So this is what we discussed and what we presented with Ministers Beke and Frank van den Broeke. And they were actually willing to listen. And actually, it's always difficult to say if this has any influence on policy making, but this seems to be the case that there's more money flowing to mental health care. So at least the topic is on the agenda. I think with respect to young people and how to represent them, well, the first thing we discussed within the working group is, the criteria of what is optimal transition. Do they actually represent optimal transition for young people? And I think a number of interesting topics were set there. I said, well, one thing is we don't always need transition. We need to know where to go if we have problems, but maybe it's a good time to say, okay, I've already come a long way. I think I can do without a mental health care professional now, but when I do have symptoms again, where do I go to? So that's one thing that came out very clearly. You need to do it in time, and you need to discuss what are really the care needs and what type of professional do they really need. You have to, of course, organize this transition meeting. That's very important. And then involve young people, which seems very obvious, but is often not done. I think there also were a number of very interesting comments. So information transfer is one of the key items. You have to have good information flow from one doctor to the other. And there young people said, maybe we don't want that. Maybe we should have the chance to start all over again from scratch. Or at least discuss with us what are the things we want the other doctor to know and what are the things we'd like to tell ourselves, for example. This is really very important. And the other thing which is very important is that when you're very young, your parents decide everything for you. And then when you're 18, you're adult and you can just decide all of this yourself. And they said, well, this is actually a bit of a developmental task. We don't really know how to do it. So you have to learn and discuss, privacy issues. What do you want to share? Is it okay if I decide not to share this, but I want to decide to share something else? So this is really a developmental task that we need to be aware of. And the third thing about parallel care is that the model proposed by Swaran Singh is quite medical. So you have parallel care between the child psychiatrist and the adult psychiatrist. Actually, relational continuity is the key here. And of course, this is not only done by professionals. The family is, for example, a very important factor in providing relational continuity, or peers. It's very important to involve peers who've been in the same situation, and that they have the possibility to discuss this, for example, with these peers. And they explicitly describe self-stigma, like I'm 18 now, I'm adult now, and I still need to go to a mental health professional. So in order to reduce the stigma, it's really nice to have young people who are in the same situation before them, and to discuss how this went for them, for example. And there's a funded project in the Netherlands who really developed, together with young people, a number of, forms to fill in together to do this. So I think what came out, and what we also gave as a recommendation to the politicians, is really try to support peer mentors, peer groups, and try to think of a way how to involve them in the transfer process. So, this is the entire list of actions we think are needed. I won't go into detail. I think I said most of them. But really involve young people structurally in, policy making is a very key recommendation here, I think. But as I said, this is on the website of Staten Generaal if you want to read about this. Okay, so who is right now? One or the other? I think this is a wrong question, and I think this is one of the problems we have with transition psychiatry, is that we didn't really define transition psychiatry, and so people are talking about different things. I think Swaran Singh is more about talking about those young people who are already in care with child psychiatry, who need to be transferred to adult psychiatry at a given age. For example, people with ADHD, people with autism disorders, or mental problems at a very young age. Of course, you want to stay with your professional for as long as possible and then make a good transition. So this is one part of what is going on. I think Patrick McGorry is not talking about this group at all. He's talking about young people who develop new symptoms. For example, at 14, at 15 or 16, who become anxious or who become depressed or who become psychotic, and then go look for a place to have mental health care. And so this is, I think it's a different group, that they don't listen to each other. That's my proposition. And they should, because they're psychiatrists. We should listen. So just as a very brief, just my ideas for what could be a meaningful strategy for transition psychiatry in Belgium. Well, the first thing is listening to our young people. I think what struck me the most is how easily we define criteria. For example, what is good transition care? And then if you talk to young people, there are still quite a lot of things that you haven't picked up on, which are not on the optimal criteria list. So we have to work with the young people themselves to really find how to go about mental health care for them. And so this is one of the topics we will be addressing with the money of the chair. So Eline Wittevongel is one of my PhD students who will be doing this. So at different levels, we will ask both young people and professionals and family their opinions about mental health care. And so we will be doing a very broad survey in the general population. So we have now finally permission, I think 2 weeks ago, to have a questionnaire to random young people across Flanders in 10,000 young people. We will also ask the same questions in young people with experience in mental health care and in professionals and family members. And what we will be doing is describe a number of cases and then ask them, okay, so what do you think? You have here a young person who feels a bit down, who is anxious, who smokes a bit of cannabis. So what could be useful intervention? And this can go from, I don't know, taking vitamins or standing on your hands, I don't know, to actually talking to a psychologist or a psychiatrist, very broad. And we hope to learn, what are the interesting strategies here. We will also do a description of services and ask them about what are the most important aspects of these services. And of course, we know the answers. You have to be accessible, you have to be free, you have to be qualified, you have to have a cool building. So we know all that, but we don't know what is truly the most important thing once you don't have money flowing everywhere. So if you have limited funds, what are the most important things to go for? And we will do this with a discrete choice experiment. So really describing different services, one who is accessible but very expensive, for example, and the other one who is with highly skilled personnel but in a very old, ugly building. And so we will ask them, okay, so what service would you prefer? And so they have to choose. So if they think qualified personnel is important, they have to go to the ugly building, for example. And we already did a pilot study, and what came out there already significant with only 30 participants was, for example, young people really want to go individually, have individual contact with a professional, and they're willing to pay a lot of money for that, rather than going to, for example, a group therapy for free. So this is a very preliminary conclusion, but I think this is already informative in terms of what you can say to politicians, what is important for young people. So this is one level, and then we will go to mental health institutions and say, okay, what is your current service? Can you describe this and this and this and this and this item? And how does it contrast with, let's say, the ideal service you have? And so we have this in young people and we have this in professionals, and we will try to identify big differences between professionals and young people. So where is the care system lacking in what young people ask from us? And then a final part of the study will be a Delphi study. So a Delphi study is a way to formulate guidelines, so clinical guidelines based on several rounds of discussion. So we have discussions with young people, professionals, and family members in several rounds to eventually end up with a number of guidelines that we can give to politicians and say, here, this is what people want. So can you give us some money, please? So this is the research. We will hopefully present the data in a year, maybe a year and a half. This is another event we will be doing, which is basically listening to young people as well on key topics. For example, how to address safety, because if you want, for example, if a young person is suicidal, you want to make sure this young person is safe. But how far can you go before you can? I mean, can you say, okay, stop, you can't go there? And where do you limit freedom versus safety? This is an important discussion where young people really wanted to discuss about. And I don't remember the others. Hold on. Yes, how does an ideal healthcare professional look like? How should he behave, etc. And so there are a number of workshops we aim to do with young people. There will be pizza and beer and Coca-Cola and all the things that young people and some older people also really like. And so this is really new. I know how to give a symposium. You invite speakers and you end up with interested people who are usually professionals and a few parents maybe. So this is a bit scary, I must say. So we hope that young people will actually come and that we don't end up with a lot of professionals who all drink beer and chat a bit. So wish me luck, or wish us luck. But this is something I very much look forward to, discussing with young people. And I think, to answer the question, what would be a meaningful strategy, I think we really need to separate or differentiate the transfer process from mental health care for young people. I think using the term transition psychiatry for both causes a lot of confusion, so it's a bit annoying that it's the chair for transition psychiatry, but I'm okay with that for now. But I think, from a content point of view, these are really two different things. They're both in young people, they both have something to do with mental health care, but they're also very different. So I think we need to redefine the terms we use. So use the term transition management or transition care and, youth mental health services or jong volwassen psychiatrie, something like that. And then I think if you do that, then you have a much more logical way of going about, the discussion versus is Swaran Singh right versus Patrick McGorry right. I think if someone is in good care with a child psychiatrist, you have to use the fact that we can be flexible with the age at which people can go to an adult psychiatrist to our advantage. I think this is a very key difference from the UK, where you have to move at 18. And so I think, for example, a person with autism, we know that adulthood or transitioning into adulthood is very difficult. It's a really difficult period. If you look at the literature, I'm not an autism specialist by any means, but I think there are a number of things that are important. You have to maintain supports you have to have trained professionals who can help you with the skills you need. So the social skills, for example, or emotion regulation, you need continued support. So what you need is flexibility regarding transition need and the moment of transition. So I think this is the Swaran Singh argument. If people are in good health, in good care, maintain the care until the moment arrives that you can transfer to an adult psychiatrist, prepare this well in advance, and do this in a good way to involve young people, to involve the family, etc. I think the second discussion is if you have young people who develop symptoms for the first time, during adolescence, for example, then you need specialized services who know how to work with young people who don't start from a given psychiatric diagnosis, like I'm 16 or 17 or 18 or 19 and I'm now at a psychosis ward or a ward for anxiety of depression. I think we need transdiagnostic clinical teams to help address the needs of young people in this age range who develop symptoms for a first time. Right? So I think that's the Patrick McGorry paradigm. So you need to be flexible for these people, youth-friendly, focus on new onset psychopathology from a transdiagnostic framework, and be really, really accessible. So you can be embedded in the first line, but with a good link to specialized care. And I think, at least in Flanders, I don't know how the situation in Wallonia is or in Brussels is, but in Flanders you now have a number of specialized transition units in hospitals as well. So if people really have serious problems, they can go to this specialized care. So these are a number of initiatives we already have in Flanders doing just that, so focusing on young people from a transdiagnostic point of view. Some of them are in hospitals. You see a number of hospitals because, usually in Belgium that's where the money is, in hospitals. I think coming from a Dutch person, so who doesn't know anything about Belgium for the us. But there are also initiatives like Overkop or Holmar that are really in the community and funded in a different way. For example, this is, I think, funded by the region, and the other ones are funded by the federal government. So it's complicated. It's Belgium, but I think we have a way forward to really improve the care of for our young people. So thank you.